So welcome Professor Rhim.
Thank you, Professor Wang, for your kind introduction. First of all, I'm really happy to meet the many Taiwan friends in person, including my family. Today, I'm really honored to be invited to the World Best Tumor Ablation Society TATA meeting. Today, I will tell you about the exit story. Where are we now? In other words, what is the current status of a tumor ablation, liver ablation? According to the Dr. Liang Ping's papers, almost half of papers were published from Asian countries. We should be proud of it. Besides this landmark 2 study from Japan and Korea, recently one important randomized controlled trial from Japan, so-called SELF study, demonstrated there is no significant difference between surgical resection and ablation for small HCC. So ablation can be considered even if resection is feasible. Thanks to the many our friends from ACTA, ablation finally survived in many HCC treatment guidelines as a curative treatment for early stage HCC. In most treatment guidelines, ablation is accepted as a curative option for early stage HCC. Liver transplantation, resection, and ablation are treatment of choice when available and feasible because of their curative potential. But what still matters? Today we are ready to talk about tumor size, tumor location, and conspicuity, and one more, tumor biology. For larger tumor, we can use more strong weapon, microwave, or we can use multiple RF electrode, or we can combine TACE. For difficult location, we can use artificial fluid or different safe energy source, including cryo and ILE, and also we can combine TACE or we can switch to radiation therapy. What about conspicuity? For inconspicuous lesion, we can apply fusion and contrast lens ultrasound, and also we can combine TACE. For aggressive tumor, showing the high tumor markers and microvascular invasion finding in MR, at that time we can refer more curative treatment to surgical resection. Today already the really excellent Taiwanese speakers covered all these issues for difficult lesions. Okay, ablation is a curative option for early stage HCC. Tumor size, location, and conspicuity and biology still matter. Ablative margin, we already know well. So how to choose the applicator to achieve the best results? Ablative margin 5 to 10 millimeter surrounding the index tumor, already well-known factor to guarantee the best outcome of local tumor ablation because of microsatellite nodules around the index tumor. As you can see, if the tumor size is larger than 2.5 centimeter, the microsatellite nodule is abruptly increasing. That's why if the tumor size is bigger, we should consider more thick ablation zone. R0 corresponds to resection for cure and complete remission. Likewise, H0, ablation with clear ablative margin more than 5 millimeter are critical factor for local tumor control. So depending on the tumor size, we should be applied tailor-made ablation strategy from simple RFA to microwave or even combined treatment. Most popular and conventional technique is a single applicator with overlapping ablation. But as we all know, the problem is it is inaccurate procedure due to microbubbles, especially for beginner. To minimize the overlapping ablation, there are many novel devices for RF ablation, expandable electrode and perfusion electrode or no-touch electrode. And also we can switch more strong weapon microwave antenna. Already 15 years ago, my friend Fred Lee said, "Oh, poor Professor Rhim, RFA is almost dying." But still, my answer is not yet, because unfortunately there is no scientific evidence of survival benefit of microwave ablation over radiofrequency ablation. That is the one reason. In Korea, microwave ablation is really behind Western country. We started 2018. Recently, I performed one clinical trial using new wave microwave ablation system, and then I performed the experimental study to assess the tissue contractibility. After this experimental study, I decided to purchase Imprint because of providing more spherical ablation zone. And also in Korea, still multiple RF electrode is more popular than microwave ablation because there are clear advantage to provide reliable, sufficient ablative margin and no track seating. And also many clinical studies using the multiple electrode show the better local tumor control rate than single central punctured ablation or overlapping ablation. And also in Taiwan, there are many good papers from Taiwanese friend to prove the switching monopolar ablation. So RFA is still, it is time to retire. I would say not yet, because no survival inferiority to microwave ablation and because of no-touch RFA technique. So when do I have to choose the microwave versus radiofrequency ablation? This is the topic of my talk today. After getting some experience on microwave ablation using Imprint, I found very simple factor. Maybe all of you in this room already know well. So I would call the exit of tumor. I think this could be a key. If you look at the many brochures from many companies, they don't tell the tumor. They only tell the ablation size, ablation configuration, power, and time, okay? But we should check the tumor in this diagram. The tip of electrode should be placed at least 5 millimeters beyond the posterior margin of tumor. If not, we cannot get this kind of ablation performance. So I would define the exit is the posterior margin of a tumor along the expected, along the potential electrode path. So from entrance and to the exit. So this is the topic of today. So I would define the exit tumor is defined as a tumor with more than 5 millimeter space beyond the posterior margin of the tumor. So this is a good example. This is a exit tumor. If the tumor is exit tumor, if we insert electrode in central portion, we can easily sufficient ablative margin. But unfortunately, there are many more tumors don't have the exit, especially like this, especially for subphrenic or subcapsular tumor or perivascular tumor. Okay, this is the example for no exit tumor. A very frequent condition in our practice. So if the tumor is a non-exit tumor, if we try to ablate with a single ablation, definitely the posterior ablative margin is insufficient. We already know well. So if you try to achieve more posterior ablation zone like that, at that time we can encounter the complication. right? For example, if it deep insertion beyond the posterior margin of tumor, we can encounter the diaphragmatic thermal injury or bile duct injury or thermal portal vein thrombosis infarction or peritoneal seeding. On the contrary, if you pull back to avoid any kind of complication, thermal injury, at that time, the posterior ablative margin is more insufficient. That's the reason of the poor results for non-AIT tumor, not just location, I mean. So if you pull back to the concerning thermal injury, as you can see, this area, the posterior ablative margin definitely problem. So there is a clear dilemma of no-AIT tumor, complication versus insufficient ablative margin. So how to choose applicator currently? I select 4 items: tumor exit first, and tumor conspicuity, and tumor safe location, and tumor size, 1 to 2 centimeter. If the all factor is a yes, at that time I use single microwave ablation through the central puncture. But if there is any no, at that time I switch to multiple RF electrode. I will explain this with several cases. The 1 centimeter recurrent tumor in segment A, as you can see in the middle of the liver. On ultrasound, the conspicuity is not so bad. What about the exit or non-exit tumor? I think it is very simple, the exit tumor clearly. At the time, all factors are yes, so I definitely choose currently the single microwave ablation. The yellow circle is the tumor size, tumor margin, and the red circle is ablative target ablation volume. If I am sure that I can insert the applicator central core of the tumor beyond the posterior ablative margin, I prefer the microwave ablation. After just 4 minutes later, you can see quite enough ablation zone with enough circumferential ablative margin. The second case, 1 centimeter of the segment 6, very similar, not subcapsular, no vessel. On ultrasound, definitely, I would say this is exit tumor. In this case, clear exit, conspicuous and safe location, and 1 to 2 centimeter. I choose the single microwave ablation. Like this. Okay, a pretty ideal ablation in 5 minutes. What about this case? 1 centimeter recurrent tumor in segment A dome. The frequent condition in our practice. The high dome lesion, just subphrenic lesion. If you approach the left side reverse direction, it is okay, but I would say this is a no-exit tumor. And also safety is also, you can change it with artificial cysts, but exit is if you apply right-hand approach, there's a no exit, no ideal exit. In this case, we don't use microwave ablation. We use 2 RF electrodes, like a chopstick technique. This is more easy and more reliable method to circumferential ablative margin compared to just single microwave ablation. What about this case? 2.2 centimeter recurrent tumor in segment 5, a pretty big tumor. On ultrasound, very clear, conspicuous, definitely there is an exit. I would say the exit tumor. But according to the tumor size, I think 2.2 is a little bit bigger than my expectation. In this case, I don't do the single microwave ablation. I use 3 radiofrequency ablation to achieve enough ablative margin. If you use the microwave ablation, maybe I think at least 2 overlapping ablation is necessary, right? So the final case is 1.7 centimeter. Looks okay. 1.7, but conspicuous is not so good. Clear exit, I would say exit tumor. But in terms of conspicuity, I'm not satisfied. So I performed the contrast enhanced ultrasound. On arterial phase, the conspicuity is not so bad, but portal and Cooper phase, conspicuity is not so good. So I choose multiple RF electrode like this for just 8 minutes. So ablation zone like that. If you use a single microwave ablation, I think it is hard to get this kind of ablation zone. But there are several pitfalls when we apply single ablation. We already know well the moving electrode due to the respiration. And also, real central puncture is more difficult for smaller tumor, 1 centimeter tumor. When the patient is expiration, at that time, the ablation zone is a little bit pulled back. The posterior oblique margin is usually insufficient. For 1 centimeter tumor, it is really hard to real central puncture because the tumor is a little bit slipped away. In that case, I think even for smaller tumor, I think 2 applicator is more safe and more reliable result. So today, I just simply introduced the exit of tumor concept to you for choosing the proper applicator, including microwave and RF ablation. For all conditions are satisfied, I strongly recommend the single microwave ablation, but the others, we should consider the multiple, the radiofrequency ablation. So I would say the exit concept can be a smart key for successful ablation to achieve circumferential ablative margin. So just remember 2 seconds. If the tumor has this character, I strongly recommend the single, the center punctured ablation. Thank you for your attention.
Thank you, thanks for a very comprehensive and so touching speech from the Professor Rhim. Is there any question from the floor?